are the topics: palliative medicine, hospice, symptom management, code status, and artificial nutrition and hydration. So we're going to start with palliative medicine. Some definitions. Palliative medicine has been defined as medical care that focuses on providing patients with relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis. So the concept behind palliative medicine is to improve quality of life. That's kind of it in a nutshell. We do a lot of aggressive symptom management. We give a lot of counseling and guidance to patients and families. And we hold discussions with patients and families regarding prognosis and options for cure. And when I talk to families about this from a palliative medicine standpoint, I make sure that the families understand that there's a spectrum of care. There are many options that they can choose, from doing everything and doing all aggressive care that's possible to doing comfort care only. And I'm going to mention at least one more time during the evening that we never withdraw care. That's really kind of a pet peeve of mine. People say, well, we're just going to withdraw care. We're not withdrawing care. We're just changing the focus of care. So you can have a focus of care that can be from aggressive to palliative. Palliative care has also been defined as the active total care of patients whose disease is not responsive to curative treatment. And this is good. It's got some good meat in it. I don't know if it's really true that they have to be patients whose disease is not responsive to curative treatment. We can certainly provide palliative care for patients who are hoping for a cure. There's been a lot of work lately involved in trying to get palliative care involved, for example, with cancer patients from time of diagnosis. Now, we all know not all cancer patients are going to die from their cancer. But palliative care from the beginning can help make the treatments easier, can help with counseling, move the family through what can be a very difficult course of treatment a little bit more smoothly and more comfortably. Basic principles of palliative medicine: affirms life, regards the dying process as normal, or regards dying as a normal process. Dying is part of life. We're all going to do it, everybody in this room. All of our parents, all of our loved ones, it's part of being human. I mean, you're born, you're going to die. Palliative medicine neither hastens nor postpones death, and you're going to hear that in hospice as well. It's one of the freeing things in my job, especially when we talk about hospice, is that I understand that my patients are very likely to die. But it's not, they're dying because of their disease process. And it's not my job to change the disease process. It's my job to make their days the best that they can be right now. We focus on relieving pain and other symptoms. We integrate medical, psychological, and spiritual aspects of care and offer support system to patients and their families, their loved ones, whoever is involved. So that's palliative medicine. You can think of palliative medicine as like the umbrella, and hospice is like a little piece underneath of that. So hospice is a specialized type of palliative medicine specifically for patients who have terminal illness. So it's for patients who are towards the end of their life. Medicare guidelines define hospice patients as having a prognosis of 6 months or less if the terminal illness runs its normal course. So they are patients that would be expected, or we would not be surprised if they were to die within the next 6 months. We focus solely on the patient and family's comfort, dignity, and goals. Care in hospice is provided by an interdisciplinary team of professionals: doctors, nurses, counselors, social workers, volunteers, home health aides. Everybody is involved in the care, and everybody has an important piece to play. Hospice care can be provided in several settings. Most hospice care is provided in the patient's home, whether it's a family home or residence, a nursing home, group home, assisted living. Wherever the patient is, we'll go there to provide the care. If that is not possible, then we can do care in an inpatient setting, a hospice house, a hospital, a nursing home, where they're receiving around-the-clock skilled care. So I will talk a lot about the hospice philosophy, and I just love this. This just sums up the hospice philosophy in one slide. It says, "Today I will live in the moment, unless the moment is unpleasant, in which case I will eat a cookie." That's pretty much sums up my life. All right, so Hospice provides support and care for people in the last phases of terminal illness so that they may live as fully and comfortably as possible. It's been said, hospice providers aim to give you the best day that you possibly can have today. It's not about, like when you talk about cardiology, for example, it's like, you'll take this aspirin so that it's good for your health and you won't, in years to come, you won't get a heart attack. Not thinking so much out there. Today is what I will want to focus on hospice. Again, recognizes that the dying process is part of the normal process of living and affirms life. Neither hastens nor postpones death. Okay, so I talk to a lot of people in the hospital as palliative medicine consults who are trying to decide what their goal of care should be at this point. And many of those people will choose to go with hospice care. And sometimes when I talk to other professionals, they can't understand why that is. Why would anybody give up and stop aggressive treatment? There's actually a million reasons. These are some of the most common. Patients are often tired of invasive treatments in hospitals. They're tired of being poked and prodded. They're tired of having tubes and tests and scans and things, and they want it to all go away. Believe it or not, there's a lot of people out there who don't like doctors. I know it's hard to believe. It's a little bit hurtful, but it's true. People don't like to go to the doctor. We make people nervous, and we do painful things. So they want to stop that. Oftentimes, really, is because they want to either go home or stay home. Home is so important to people, especially when they're sick. You know how when you're sick, you have like the flu or something? I think probably everybody has had this experience. You went to work or school, you felt fine when you went, and then something hits you all of a sudden and you've got a headache, you're nauseated, something, you've got a fever, you feel terrible. What's the first thing you want to do? You want to get home, right? Home is very comforting. Often people want aggressive symptom management, more aggressive than they can get if they're still getting aggressive treatment. Sometimes just no curative options exist, and hospice is the best of all the choices. You'd be surprised how many people want hospice for their family. The patients will tell me, you know, I'm okay and I feel like I could be okay and I could deal with this, but I really want the support from my wife, my daughter, the caregiver. They want that support for the whole family that hospice can provide. And also they need help with grieving, both the patient and the family. And we're going to talk a little bit about bereavement as we go through here. And remember that bereavement starts before death, and that the patient grieves too. The patient grieves their own death. They grieve the loss of independence, of mobility, of their health. And the family around them is grieving while they're watching their loved one deteriorate. Bereavement care continues with hospice for, well, pretty much as long as you need it, but officially for 12 to 13 months after the patient dies. So we don't just drop these patients after they die, okay, see ya. They're followed by the hospice team for a year afterwards. So here we're going to talk about hospice. These are the services that hospice provides. So when a patient elects hospice benefit, they become eligible for a spectrum of services. In-home nursing care, social work support, which is hugely important. This is support for financial issues, insurance, housing, care situations. The social workers are miracle workers, I'm telling you. Chaplaincy, spiritual care is so important at the end of life. Bereavement care, we just talked about. Home health aides. The home health aides will go into the home and they do personal care, they do bathing. I have home health aides that will cut hair, they do their nails, all of the little things. And when the patients talk about the people that they're most attached to, it's always the home health aides. And if you have home health aides, if you're lucky enough to work someday in a situation where you have home health aides going into the home and you have contact with them, trust me, they know those patients and families better than anybody else, because they're like a fly on the wall. They're giving a bath, they're brushing the patient's hair, they're helping the patient dress. When I'm in the home, all eyes are on me. The doctor's here, we have to ask questions, we have to, and it's like this, right? And everybody's paying attention. I leave and the home health aide is there, and she's just doing her job, and but she's listening. She hears everything. She's the one that can tell you, the daughter and son-in-law are going to get a divorce, and did you know the patient has a bruise on her shoulder? They're fabulous. We have a huge group of volunteers that provides any kind of anything you can think of. And hospice will also provide some coverage of medications and durable medical equipment. So when a patient is on hospice, you get back to the hospice philosophy. The treatment should be provided for comfort rather than cure. Hospice will cover medications for pain, dyspnea, anxiety, for symptoms. We're going to provide these in as non-invasive a manner as possible. So we're going to try to use the PO route if we can, sublingual. I can count on one hand the number of intramuscular injections I have ordered in the past year. It does happen every once in a while, but ouch! If I'm never on hospice, don't stick me with a big needle. You can save a lot of pain and suffering on the part of both the patient and the family if they have these discussions up front. Okay, so these are the non-pain symptoms that we're going to talk about. Dyspnea, respiratory secretions, restlessness, nausea, vomiting, diarrhea, constipation, anorexia, cachexia, fatigue, asthenia, and weakness. You see why we're going to go fast? Okay, so dyspnea is shortness of breath. It is the subjective feeling of shortness of breath. I like the term air hunger because it sort of gives you the idea of what it actually feels like. I don't know if any of you here have actually experienced true feeling of I can't get a breath, but we used to say in medical school, if you can't breathe, nothing else matters. It quickly becomes the most important thing in patients' world. So it can be from obstructive or restrictive lung disease, weakness of the diaphragm muscle, from neurological issues, tumor or space-occupying lesion, pulmonary edema, so you've got fluid, air in the thorax, hemothorax, or airway obstruction or inability to manage secretion. So lots of different things. So as you're going through and thinking, what's going on with this patient, what might I be able to fix? So non-pharmacological treatments for shortness of breath. Positioning, keeping the patient so that they can use the most of their lungs. So that means keeping them upright if they have fluid in the lung bases. If they've got a big obstructing lesion on the left side, so they're not using their left, tip them over to the left so that they have less pressure on their right side, they'll breathe better. Breathing exercises, if you're early in treatment, can be effective. Adequate rest between activities, and this is going to pop up a few times in our non-pharmacological treatments. One of the things that specifically as healthcare providers that we can do is we can give the patient permission. In front of the family and the loved ones and the caregivers, we can give them permission to rest. It's okay to feel tired. It's okay to get up in the morning, get dressed, and then be so tired that you have to take a nap on the couch. That's okay. And sometimes by us doing that, you don't realize necessarily yet how much authority you will someday be able to command. It's a little bit humbling. But you can make life so much easier for both the patient and the family by just giving your bliss. Okay, I understand, you're tired, it's fine. And then the family will come to accept it a little bit better too. Oxygen is a funny thing in symptom management. Oxygen is great for hypoxia. Hypoxia is not always the problem that's causing the feeling of shortness of breath. So I have no problem. Oxygen is dispensed to, actually I just found this out, oxygen is dispensed to every single hospice patient. They get an oxygen concentrator in the standard package. I didn't actually realize that. They don't all use it. Not most of them. I think, what was the number that I just saw? Something like 44% of, these are just my patients in Wellmont Hospice, are using the oxygen. The rest of them have a tank or a concentrator in the closet. So in case they would need it or the family would want it, then it's there. I don't mind if they use it. Sometimes it'll help, sometimes it won't help. Thoracentesis, paracentesis, if it's appropriate. Again, this involves a big needle and it's not very comfortable, but if it buys some time where they're not so dyspneic that they can't interact with their family and loved ones, then maybe it's worthwhile. Counseling, guided imagery, meditation, mostly for the panicky type of shortness of breath. Medications, lots of medications, opioids, benzodiazepines, bronchodilators for patients who have obstructive lung disease, steroids to decrease inflammation, diuretics if you've got a fluid problem, anticholinergics, antihistamines if you've got secretions. Terminal secretions. Terminal secretions are kind of a big deal. Sometimes called the death rattle, and I try not to say that to patients and families, but you'll be shocked at how many times you'll walk into the room and you'll hear the patient, and they've got, basically what it is a little bit of, just a little bit of phlegm, essentially. It's a little bit of respiratory secretion that gets kind of stuck in the posterior oropharynx, trachea area, and the patient breathes over the top of it, and medical literature suggests that it doesn't bother the patient very much, but it's pretty, sometimes you can hear it right when you walk in the door, and it drives the family nuts. And the family will come to you and they'll say, "Is that the death rattle?" Okay, yeah, probably. That's what we call it. It is really distressing to family members, and it's one of those things you feel like you ought to be able to suck it out. So sometimes you try to go in there with the oral suction. It rarely works, and I'm telling you, if it does work, it'll come right back. So usually I don't do that. Deep suctioning, I almost never do. I mean, it's very, very rare that I would do that in end-of-life care. So what do? We give them medicine to dry them up. So we may use atropine drops. Atropine is an anticholinergic. She used to be used to dilate the eyes, and still will dilate the eyes, but it can also be given sublingually or in the buccal mucosa. Will be absorbed and will really help dry up that secretion. We'll also dilate their eyes, by the way, so don't be surprised. And I think what I've heard is you can put it in the eyes and it will also help because it's a systemic effect. It's just kind of an interesting thing. When you go to write a prescription for atropine ophthalmic drops to be given sublingually, about half the time the pharmacist will call you and say, "What in the world are you thinking of?" It's okay, just explain it to them. They haven't had my class. Scopolamine patch, that's the little patch that we put behind people's ears when they're, little old ladies' ears when they're going on the cruise. I'm not a big fan of scopolamine, especially in end-of-life care. It takes a long time to come on, and it's just so many, then once it's on, then you can't get rid of it, and some of these anticholinergics can have a lot of side effects. They can make you kind of crazy. So, especially atropine and scopolamine. Glycopyrrolate the brand name is Robenol, and there's a problem with glycopyrrolate, which is that it has to be given either subcutaneously or IV. So it requires a needle, and I'm not really fond of needles, but I do use them if I have to. The good thing with glycopyrrolate is it doesn't cross the blood-brain barrier, so it doesn't have as many psychiatric side effects. Delirium, and I'm using delirium here to mean a lot more than really technically delirium. So agitation, restlessness, patients get uncomfortable. Often has many qualities: reduced level of consciousness, may have hallucination or paranoia, memory loss, disorientation, disturbance of sleep-wake cycle. Sometimes we call this sundowning or getting the days and nights confused. This is probably one of the top 5 reasons for use of respite care. Respite care. It's because people, as they get closer to the end of their life, for some reason, it's sort of like babies. They want to sleep all day and be awake all night. I don't know why that is, but it does seem to happen. Disturbed motor activity, and symptoms often wax and wane. So they'll be good for a little while. Usually what happens is their patient is very agitated, restless, batting, combative, and then when I walk in, they're sleeping. I don't know why that happens. I seem to have that effect. I think maybe it's because the nurse just gave the Ativan 30 minutes before I got there. Because I walk out of the room going, "I don't know, he looks fine to me." And they were going, "Oh my gosh, he was up all night." So remember to assess for underlying conditions. Lots of things can cause restlessness, agitation, delirium. The one that I singled out was spiritual distress. Don't forget about this in the end-of-life patient. Spiritual distress can be huge for these patients. A lot of times when I have a patient who is agitated, who is just clearly distressed, doesn't seem to be in pain, but is just restless and angry and combative and trying to get out of bed, and I've given them some Ativan and nothing's changed, and maybe I've given them some other things, maybe tried to treat their pain, things, and nothing that I'm doing, like nothing seems to make a dent. That's when it always triggers in my mind to think of what I call a stat chaplaincy consult. And I have seen that, I mean, so many times, I just can't even tell you. The chaplain will come and address spiritual concerns. Sometimes the patient can't even talk, but I don't know. People get in spiritual distress at the end of life. So don't forget about it. Again, communication with family is key. Communicate early and often. Some non-pharmacological things, normalizing the light-dark cycle, reorientation communication, making sure that you keep reorienting them. You know, this is the day, this is the time. It's lunchtime. Consistency with the daily cycle, activities during the day, sleep at night, sleep protocols. And this is an old slide. We had this, in fact, I had a recipe card for it in my old hospice, and I'm thinking that maybe I should get that again. It was a recipe for a banana milkshake. Now, bananas and milk both have a lot of tryptophan, and tryptophan tends to promote sleep. The sugar was to help the tryptophan go across the blood-brain barrier, be more effective. I was surprised at how well my banana milkshake worked for settling people down about half an hour before sleep. It's got no side effects except maybe weight gain. Remember to address vision and hearing issues. A lot of times they don't have their hearing aids in, they don't have their glasses on, so they can't see you, they can't hear you. No wonder they're confused, right? We forget about these things at the end of life. We may not even realize the patient needs glasses, but they are unable to identify people because they can't see them. So basics, always think back to the simple things, the easy things, the common sense things. These are the things that tend to get forgotten when we're busy writing for phenobarbital or ativan or something. Remember to assess for polypharmacy all the time. Consider chaplaincy. Neuroleptics, Haldol is highly used in end-of-life care, benzodiazepines, and sedatives, barbiturates. Phenobarbital is a good drug. It's an old drug. It's very sedating, but it's really good for seizures. So this is kind of an example of using a medication whose side effect may actually be a benefit more than a burden. So if I've got a patient who's got a history of seizures and they're restless, yeah, that's good. Okay, anorexia and cachexia. Anorexia is loss of appetite. We're going to talk a lot more about that when we talk about artificial nutrition and hydration. Cachexia is basically loss of weight with or without loss of appetite. Sometimes you see in end-of-life patients, cancer patients, heart patients, even though they seem to be eating, they're just, the weight just kind of melts off them. They waste anyway. Lots of reasons why someone could lose their appetite. Sometimes they're just in too much pain to eat. Sometimes they have pain when they swallow, or they can't swallow well. They can't swallow effectively. Sometimes they're nauseated and just the thought of food makes them sick to their stomach. Sometimes they have depression and they just don't want to do anything. And then there's cancer and some of the chemicals that the tumors can excrete into the bloodstream, cytokines, interleukins, those kinds of things. And end-stage cancer patients have a tendency to not have any appetite. And I seem to have this conversation a lot with patients and families, cancer patients and their families, that the cancer it's more than you think about it. And you think about it's like this big softball, baseball thing that's just sitting in your chest and taking up space. But it's actually more than that. It's actually starting to interact with your body and change your body chemistry. And so it does more than just sit there and take up space and cause problems that way. So I'll always remember that. Sometimes, it may seem obvious to us, but it's not always obvious to the patients and families. And this can be really difficult emotionally for the family. Food is associated with nurturing in our culture. Food equals love, I'm telling you. And down here in the South, it's even more pronounced than on the West Coast or some other places where I've worked. Really is a cultural thing, and it's really well ingrained. And I just can't tell you how many times people have told me, I don't want Dad to starve to death. I just can't stand that. Because they feel like if they're not feeding their loved one, then they're not showing them that they love them. So some of the things that we can do. Lifting dietary restrictions. That's one of the best things about being a hospice doctor is I get to tell people they can eat whatever they want. It's up to them. It's all about them. So if they want to eat cake 3 times a day, I'm fine with that. And so allow the patient to control the food intake. Don't make mealtime a battlefield. If the patient wants 3 bites of cake and throw the rest away, I'm fine with that too. Add calories and protein unobtrusively if you're taking care of someone and you're trying to keep weight on them. You know, a little extra butter on the potato, a little extra peanut butter in the sandwich. And you can get calories. All those of us who have tried to cut out calories that way know how fast they rack back up if you're adding them in. Observe rituals. Oftentimes meal times are about ritual. They're about saying grace and sitting down at the table together. So even if you're not actually eating a lot, you can still sit down at the table together. Sometimes if you serve cold food, it will have less aroma. You may use nutritional supplements, Boost or Ensure, dietary consults, and educating the family members is really important. Taste abnormalities are very common in the ill patients. Let the patient eat whatever tastes good. Decrease food requirements of the inactive patient. You know, even a sedentary lifestyle has a higher resting basal metabolism than a patient who's just laying in a bed. Actually, it doesn't take very much calories to keep that patient stable. And don't force feed patients. It causes more problems than it solves. And probably the number of family conflicts that I have seen that are around food, just huge. It's, you know, if Mom would just eat, she would feel better. I was like, yeah, but you know, it doesn't taste good. But if you would just eat, then you would get better. There's this sense that if they could fix the food thing, that all the other problems would go away. She wouldn't have cancer anymore. She wouldn't have end-stage heart disease. So we're going to talk about artificial nutrition and hydration later. Counseling is very important, explaining the whole situation, the clinical condition. Appetite stimulants, the key down here is that none of these work particularly well. Weight gain is often minimal and not much lean muscle is gained. I probably get the most bang for my buck out of steroids. Put someone on a little dexamethasone, perk them up for a little bit, makes them hungry, makes them feel better, makes them breathe better. So steroids are good. Nausea. Oh, we're doing all right. Nausea has many, many underlying factors. Medications, I'm probably the biggest causer of nausea. Tumor factors, cytokines, increased abdominal pressure from tumors, fecal impaction, ascites, just no room in the stomach. I can tell you this, I had a twin pregnancy, no room in the stomach, can't eat, nothing. Marinol wouldn't have helped. There was no room. Sometimes just anxiety and fear. Ever notice when you're really anxious or really nervous about something, like you lose your appetite? So if you're really anxious because you've got a terminal diagnosis and you don't know what's going to happen, you know, tomorrow or the next day or tonight, and what's going to happen when I go to sleep, you can't eat because you're too busy worrying. So you've got to deal with the anxiety. Vestibular stimulation, motion sickness, increased intracranial pressure. If you've got tumor or increased pressure in the cranium, that will trigger the nausea center. And gastroesophageal reflux. It's simple, but a lot of times we don't think about it, especially in our patients that we just put on steroids to increase their appetite. And now, guess what? They've got heartburn. Okay, so treatment, always treat the underlying condition. If you can come up with a way to treat it, it's good. Delivery, great. Got my appetite right back. Minimize aspiration risk, communication with the family and the patient. Good oral care. If the patient's mouth is really dry, if they have thrush, they're not going to be hungry. It tastes bad. Everything tastes bad. Cool damp cloth to the forehead will solve a multitude of problems. Minimize odors and other noxious stimuli. Sometimes this is a real problem. Patients who have bad abdominal wounds, fistulas, things. Sometimes it's really hard to deal with the odors. We work hard to try to make that as good as possible. Sometimes there's just not, you just work on it. Deep breathing and voluntary swallowing techniques, adjusting the diet to patient tolerance, loose unrestricted clothing, fresh air, moving air, also great. It's great for shortness of breath, it's great for nausea, it's great for panic. I mean, half the time, you know, people are panicked. It's like a claustrophobic feeling. Just a little bit of moving air will be helpful. Positioning, avoid laying flat after eating, and small frequent meals. Lots of medications for nausea. Probably the go-to medication in end-of-life care for nausea and vomiting in hospice, haloperidol. How many people knew that? It's another one of those ones where either the attending physician or the pharmacist will call me up and say, "What? Are you crazy? Haldol for nausea?" It's a dopamine antagonist, and dopamine is really involved in the nausea reflex. So Haldol, I mean, it's like a miracle. I have a patient right now in the hospice house that had Phenergan, Compazine, Zofran. I can't even remember what else. They had multiple medications, and she was just vomiting and vomiting and vomiting and vomiting. She has gastric cancer. Got her in the hospice house, gave her a little sub-Q Haldol. She told me this morning, she says, I haven't slept in weeks, and I slept all night, and I don't feel nauseated now. I mean, it works when nothing else does. The 5-HT3 agonists like Zofran, they're good for chemotherapy-induced nausea. They don't have a lot of side effects, which is nice. Almost all of these other drugs, they have lots of side effects. But I've been really underwhelmed by Zofran in general for nausea. Benzodiazepines, if anxiety is a problem. This patient also has a lot of anxiety, so I'm starting her on a little bit of a benzodiazepine as well. She sort of had that cycle where she knew every time she ate she would throw up, so she would get afraid when she would eat. So now that we've got her nausea under control, work on her anxiety a little bit, I'm thinking she's probably going to go home tomorrow and she's going to have a lot better quality of life than she did. So there's an example. She was a home patient. She came in for general inpatient care because we couldn't get the nausea and vomiting under control at home. Brought her in, and this sometimes, could she have had Haldol in the home? Yeah, she could have. One of the things about that is that she had another doctor in the home. So she's being followed by her primary care physician, which I think is completely appropriate, but he didn't think of it, so he transferred the care to me in the hospice house. I've got a few other tricks up my sleeve, get her comfortable, send her back to home, and then she can go on with her life. That's the way it's supposed to work. Anti-vertigo medications, if that's an issue, GI stimulation, metoclopramide, Reglan is a bowel motility or a gastric motility agent, helps move things along if you've got a problem with gastroparesis. If that's the problem, that will work. Decadron, if there's increased intracranial pressure, and don't forget your PPIs. Okay, everybody in the whole entire world is on a PPI these days. Hi, constipation. I think I'm getting to the end of this one. We're going to break after symptom management. Constipation is distressingly common in hospice patients, and it's usually because of something that I prescribe. It's almost always due to the opiates. Everybody who goes on an opiate should go on a bowel regimen. It's just, you know, you write for morphine, you write for Senna. It's just got to go together. You've got to be on top of the bowels from the very beginning, or else you're going to get behind, no pun intended, and it's just, you know, you're gonna fight with it. It's also due to immobility. Many of you who have experience in the surgery realm, you know, when we cut somebody open, we know they're going to have trouble starting to move their bowels again. What do? We get them up, we walk them. That's one of the most important things. What do people do at the end of life? They lay in the bed. And so they're not moving. It's not their fault, it's what we expect, but it does affect their bowels. GI blockage or ileus can be a problem, increased intra-abdominal pressure and decreased oral intake. Sometimes at the end of life, families will get either really focused on the bowels, or they won't want to worry about it. So it's okay, it's only been 3 weeks since he had his last bowel. But it's okay because he's not really eating very much. But you know, your bowel still sloughs, and you should still have some kind of bowel movements. That being said, if the patient is really close to death and doesn't seem to be uncomfortable, I'm not going to go start giving them a whole bunch of enemas or anything. So you always constantly have to be balancing that. You know, if I think that it may be making the patient uncomfortable and there's something that I can do for them, then I'm always going to be doing it. But if it's not bothering them and I think they're going to be gone in a day or two, then I'm not going to be crazy about it. So treatment, encourage mobility if possible. Increase fluids. Lots of fluids are the most important thing besides mobility, maybe kind of neck and neck. You got to have fluid in order to keep things moving, otherwise you got concrete. Bowel logs, avoiding straining, fruit juice, coffee, fiber. Take advantage of the gastrocolic reflex. That's that reflex in babies where when you feed them, they poop. We still sort of have that a little bit as we grow, and so remember that if you get somebody to eat, then put them on the toilet. You know, because a lot of times, you know, patients who are end-of-life patients, maybe they can't get to the toilet by themselves, so they have to kind of time this. And it doesn't always, you know, it's not always convenient. You can use enemas if needed, and manual disimpaction is always horrible, but can be done. Sometimes it's not more horrible than the constipation. So, but usually, once a patient has been manually disimpacted, they're much more likely to go along with bowel regimen. Turns out. All right, so we use a lot of senna in hospice. It's a good natural. It's one of the other herbal remedies that I use over the counter. You can get senna S. It has colace in it. If you just use a stool softener without a laxative, I call that mush with no push. You got to have the bowel moving in order to move the contents out. Osmotic laxatives basically give a load of sugar or electrolytes to pull fluid out into the colon. Remember, the colon absorbs and secretes water. It's mostly a water organ, actually. And prokinetic agents like Reglan if the bowel is just moving slowly. Okay, fatigue, which is what I'm feeling right now. Are we done yet? Okay, fatigue, multifactorial and very common at the end of life. It's extremely distressing to the family. They don't understand why their loved one can't get up and go to Walmart with them. It really distresses people. And this is, again, where the healthcare team can give the patient permission to be tired. You know, if her body's going through a lot, she needs her rest, she's got to sleep. It's okay. And sometimes just hearing that will make it okay for the family. Again, here's us. Medications. We give lots of medications that can make people sleepy. Sometimes that's what we're meaning to do. Sometimes it's not, and it's just the side effect of something to treat another thing. It's that burden-benefit balance that we always have to be thinking. Disease progression, this is almost always a part of it, with or without medications. And I, you know, I stick up for morphine a lot because morphine always gets blamed. You know, if the patient is suddenly having more fatigue and is sleepy and not as interactive and things, the family always wants to, well, it's because you gave him that morphine. And it might have something to do with it, but it might also have something to do with the fact that his cancer was getting worse, which is why he was having more pain, which is why I had to give him the morphine. So trying to get the family across the bridge on that is not always easy, but it is there. And you can always offer to back off on the medications if it's okay with the patient, and you know, and talk to them and keep trying to find that balance. Anemia can be very common at the end of life. Anemia of chronic disease, dehydration, depression, sleep disturbances. So lots of reasons to be fatigued. So what can you do about it? Adapt the ADLs, that's activities of daily living, to the patient's tolerance. Physical therapy or occupational therapy if they're appropriate. Evaluate for polypharmacy again. Optimize fluid electrolyte intake. Sometimes, you know, and again, this kind of gets back to that idea that, you know, you've got a lot of authority with patients and families. So that's why I put Gatorade down there. Sometimes I can, if you tell the patient and family, you know, something will work. It's, you know, Gatorade has a lot of electrolytes in it, and it can be really good if you're dehydrated. I mean, it's a half decent. It's got a lot of sugar in it, but that's okay for my patients. I don't care. Electrolyte solution to, you know, and it gives them the feeling like they're doing something. You know, you don't have to be going out and running IV potassium and all of this stuff into people. Sometimes that's not going to help anyway. So, you know, sometimes if you tell them that the Gatorade might make them feel better, well, you know, placebo effect is like 33%, right? So you can help a lot of people. Steroids are great for fatigue. Decadon, prednisone, psychostimulants, Ritalin, Provigil. Don't use them very much. There's a lot of protocols out there for using them along with morphine and some of these medications that tend to make you more fatigued, more sleepy, to try to increase mental alertness. In some patients, they will do something, but I've just really not been impressed with the results that I've gotten. If a patient comes to me on them or asks to try them, I'm not opposed to it really, but I just don't think we necessarily get a lot of good out of it. And a lot of times, you know, so often you see this patients that, you know, end of life patient, cancer patient, they're getting morphine. It's like, you know, I want to go on some Ritalin for the fatigue, okay? But you know, then you look at their med list, and they're taking Ritalin in the morning, and then about noon they're so anxious that they're taking a benzo. And it's like, well, you know, you're sort of like you're canceling yourself out here with all these medications, and you know, it's so if it works, I'm okay with it.
Dextroamphetamines. What kind of experience do you have with that?
I can't remember the last time I've used it. It's just I don't see it used very much anymore. I remember using some in primary care for certain patients that had sleep disorders, narcolepsy, that kind of thing, but in end-of-life care, I haven't really used it. So I don't know. There might be good literature out there that I don't know about, but I'm not familiar or really comfortable with using it.
Yeah, I think that there is this fear about using things like morphine and benzodiazepines and amphetamines, which if they work, now that's the question, is whether they're effective, and who cares?
Right.
So you won't want them to go on for 10 years. You don't want to.
Right. Right. At the end of life, I mean, if it would help, I would give it. I don't have anything personally. You know, I'm not worried about that. I'm not so worried. It's a nice thing about hospice medicine is that I don't have to be extremely paranoid about addiction in my patients. It's not going to be a big deal for them, frankly. Their family members who may be taking the morphine out of the bottle, that may be another issue. But the patients themselves, you know, you can use really anything that works. I mean, I will use for my patients. It's just about getting them comfortable and giving them the best quality. But I'm not worried about them ending up in Narcotics Anonymous in 15 years. If they do, good for them, because it means they've lived a lot longer than I thought they were going to. All right, let's try to go through pain real quick. I forgot I had pain in here too. Pain is really central to hospice and palliative medicine. Multiple types of pain: musculoskeletal, visceral, neuropathic, and bone pain. It's important when you're getting the story of the patient's pain to kind of be having an idea of what kind of pain you're treating, because certain types of medications can work better for different types of pain. So musculoskeletal pain, so somatic pain. This is your sprains, strains, muscle ache, muscle spasm pain. It tends to be crampy and superficial. It's located in the muscles. It's usually worse with active motion. Treatments, I mean, this is your basic, you know, I twisted my ankle kind of pain. You know, heat, ice, support. Don't forget these simple things. Even a patient who has bone pain from cancer, and we'll talk about bone pain, but you know, an ice pack might be really helpful. And support is always good. Support, splinting. NSAIDs for musculoskeletal pain are good for patients that can use them. Muscle relaxants as appropriate. Cyclobenzaprine. Benzos are great muscle relaxants. It's kind of another one of those, you know, you can get kind of like kill two birds with one stone kind of drugs. And opiates. Usually, because this is musculoskeletal pain tends to be a shorter term nature, people tend to use more hydrocodone, oxycodone, kind of your more acetaminophen blend medications for that. Visceral pain is pain that's usually associated with internal organs. It tends to be a dull, pressure, crampy kind of pain. The organs don't necessarily really, how do I explain this? When I was a resident, I did a lot of women's health, and one of the things that I did was colposcopies, and this includes taking biopsies of the cervix, which is part of the uterus. And I would explain to patients, I would always have them take some Motrin beforehand, and I would explain to patients this way. The uterus and most internal organs is a dumb organ. It doesn't know how to do anything but cramp. So if I stab it, it'll cramp. If I cut it, it'll cramp. If I punch it, it'll cramp. If I burn it, it'll cramp. So you're probably going to feel some cramping, but that's probably all you're going to feel. Does that make sense? So it tends to be kind of like that. You don't get a lot of really kind of specific pain so much with visceral pain. Doesn't tend to respond too well to NSAIDs, the uterus being kind of different because it does have a lot of muscle in it, so you've got some somatic component there too. Treatment of the underlying process, if possible, surgery, antibiotics, if there's an abscess, or you know what I always think of with visceral pain is pyelonephritis. And I don't know if you've ever seen a patient with pyelonephritis or ever had it, but yeah, it just gives you this really crampy, dull pain in your back from the kidneys. So antibiotics can work for that. And then opiates, morphine. Bone pain tends to be sharp, constant, and worse with movement. It's a really, other than sharp and constant, it's hard for me to think about how patients describe it, except that it seems to be more intense. It's a very intense pain, bone pain is. You can treat it with ice, you can splint, brace. Don't forget about these things, because even patients who get, like, I had a patient whose whole shoulder was just ate up with metastasis from cancer, and one of the things that actually helped a whole lot was to get her in like a shoulder immobilizer, and one of these big things that's like after shoulder surgery, but it kept those, the shoulder is kind of a bunch of bones that are sort of held together by a bunch of muscles. And when those bones were sort of crumbling and falling apart from the inside, she couldn't hold it steady. So just to steady that for her was a lot better. Helped a bunch. She still needed a lot of pain medication, as you can imagine, but that was really helpful. Calcitonin and bisphosphonates will help to recalcify bone, and sometimes they can be helpful in bone pain. Neuropathic pain is often seen in patients who have diabetes, cancer patients with nerve compression. It's the same kind of ideas. Also, like phantom limb pain is a nerve issue. It tends to be described as a sharp shooting electric shock burning type of pain. And you can use different medications for this. It does also respond to opiates, but neuroleptics like gabapentin, pregabalin can help a lot with neuropathic pain, and also steroids to decrease inflammation in nerves if that's an issue. Steroids also can be fairly helpful in bone pain as well. I forgot to put that slide. So, remember, communicate, collaborate early and often, burden and benefit balance, use only interventions that are appropriate and consistent with patients' goals of care, and just always try to keep in mind where the patient wants to be and figure out the best way to get there. Don't be afraid to change course if what you're doing isn't working. Radiation therapy can be used in a lot of situations where a cancer has metastasized and is maybe not curable per se, but in certain situations where you have pain from the cancer, bone metastasis, nerve pain, those kinds of things, if you have impingement from a tumor, sometimes you can use radiation therapy to shrink the tumor, even though you're not going to make the whole cancer go away. And so you can do palliative radiation therapy for that. Not being a radiation oncologist myself, I don't have a ton of detail about it, but I know that it is offered to a lot of patients, and patients who are having crippling pain or pain from an obvious lesion, I will often refer to radiation oncology. I put just a couple of cases in here just so we could kind of bring it home, and I'm a sort of a person that tells a lot of stories when I talk anyway, so hopefully I've been able to make it somewhat meaningful. But let's think about this in terms of a patient. Fred is a patient. He's 60 years old and he has a recent diagnosis of metastatic lung cancer. He's declined aggressive treatment for his disease and he elects to go home with hospice. He lives alone and he has very limited support. He has a couple of friends. He really has no contact with his family. His best friend is a veteran who happens to be legally blind. So that's who he's got to support him. He continues to smoke 4 packs of cigarettes a day. Don't ask me how this can be done. I don't even know how you can smoke 4 packs of cigarettes a day, but that's what he says. And I've seen him. He basically lights one cigarette off the other. And he refuses any oxygen, saying that the oxygen irritates his throat. What are you gonna do? Okay. It doesn't matter because he can't really have it anyway because he never stops smoking, so there's no time to... Anyways. So, what can I do to help with his shortness of breath? Because in between smoking, he can barely talk because he's so short of breath. He has to pause. In fact, at one point he becomes reduced to writing, and he can actually write pretty well, but because he can't catch his breath enough to talk. What ideas do you have?
Morphine.
Morphine is good. Morphine is good. Takes away the air hunger. It's one of those examples of using the what might be considered a burden in some cases, that kind of respiratory depression, to decrease the air hunger. Morphine helps Fred a lot, and I've been able to make him more comfortable with that. What else? What else do we talk about? Steroids. Good. Steroids will help to decrease that inflammation from all that irritating oxygen that I'm trying to force on him. But no, there's a lot of irritation, and even just with the cancer will help to decrease the cytokines and things from that will make him more comfortable.
Maybe psychological treatment. Maybe he has anxiety problems for smoking so many packs of cigarettes.
That's great. That's great. One of the things that helped Fred the most was when I got a volunteer and a chaplain and the counselor in there to see him on a regular basis. It turned out he didn't think that he was lonely. He thought he didn't like people, and he didn't like anybody in his business, and he didn't want anybody around. But it turns out once he got some people who cared about him, he was really lonely. And he actually managed to cut down his smoking a little bit because of that. Still wouldn't let me put oxygen on it, but he was able to get some sleep because I dealt with that anxiety. Also gave him a little benzodiazepine. That helped a lot. I told the nurses at one point, I said, if he gets sleepy enough and he goes to bed, slap a nicotine patch on him and see if he notices. He refused it. So I'm like, maybe he won't notice and he won't crave it as much. He would tell me, the cigarettes are like a tranquilizer to me. And that's one of the things that happens with people who smoke long term, is we know that nicotine is a stimulant, but when you sensitized your body to it and your body has gotten used to having it all the time, then not having it makes you more anxious, and when you put the nicotine back in, it actually calms the nervous system down. So trying to find another way. He will shortly become too weak to smoke anymore, and then we'll have a whole other set of issues. Anything else you can think that we could do for him?
What's his activity level? What is he doing physically?
He sits at the side of the bed and smokes. That's about it. He can get to the toilet, although he won't be able to for very much longer, I think. I would have liked to have gotten him outside, but the weather had been so bad that I wasn't able really to do that. Fan, moving air. Moving air is great, and it keeps the smoke away from me too. And this is one of those things. I'm a big proponent of not smoking, and I have myself asthma, and it becomes a problem for me to be in the same room. And when you do home care, you have to be in the homes of these people, and even if they're not smoking while you're there, believe me, it's still everywhere. So having fans and open to the outside and things are really helpful to mitigate that as much as we can.
really use Chantix, but I think about it in terms of whether it might decrease his smoking.
It's a good
There's
thought.
too many problems and side effects.
It does. But you know what? Maybe, I mean, he can still take pills. Maybe bupropion. I wonder if that would be an option for him. That's a good thought. That's a good thought. Who's going to make his decisions when he can't? He will eventually not be able to make decisions. What are we going to do then?
Advanced directives if he's not talking to his family.
So the social workers have been working a lot with him on getting advanced directives and code status and things like that kind of nailed down while he still can make decisions. He also named his friend, the blind veteran, as his power of attorney, so he can make decisions. He may not be able to care for him, but he knows him well. And just getting his preferences and things down is huge, because it helps us to know what to do for him. That's excellent. I see patients like this in the hospital more often than you would think, where the patient basically has isolated themselves from all their friends and family, doesn't have anybody around who's remotely really interested in them. So terminal sedation or palliative sedation is basically, it's the concept of kind of putting a person more or less under anesthesia, for lack of a better way to put it. It's actually a little bit more simple than that. Knowing that they will probably not come out of it and they will probably die while you're sedating them. We usually use IV Versed, something like that. Usually, we give morphine and things for comfort as well. That's a really good question. It probably is a discussion that should be had. Often,
he's afraid of being short of breath, and that's frightening to him, and we haven't really solved that problem. And he realized at some point it'd be too weak, but he still would be feeling this terrible air hunger. Would he be interested in willing to accept terminal sedation?
I think that's an excellent point. At some point, and often what you find, terminal sedation, it's a phrase that gets a lot of, it's kind of a, it's like a headline kind of thing. Oh, we're going to put the person to sleep until they die. And usually, actually probably use a fair amount of terminal or palliative sedation. It's not usually a big, today you're going to go to sleep. And it's really not that much of an event. Usually it's kind of an ongoing thing that I'm talking with patients and families about, and it goes back to that discussion that I've explained to you guys a couple times about how, I can treat the symptoms. I will always try to keep them as awake as possible. It may not be possible at some point. What are your feelings about that? And that's really actually kind of where I'm going, is there may be a point where at some point the medications that I'm using are going to be enough that the patient's going to go to sleep. And is that okay? And I think that's a really good point. I think that discussion probably needs to be had with this man, because he probably is going to need to be sedated when he can, his lung disease is going to continue to get worse. Anything else on Fred? Any other ideas? You guys got any good advice for me? Yes?
Would like a beta agonist work in this situation? I don't know how it works with lung cancer.
Maybe. And I think that he has some ordered, but it's sort of a diminishing return on that. You can sort of open up the small airways, but have you ever noticed that then it makes you really jittery and anxious? So it's, again, everything's got a dark side to it. So you could try to find a balance with that as well. But it's a good thought. It's a good thought. Oftentimes in end-stage COPD, or early-stage COPD for that matter, beta agonists can be very effective in trying to keep those airways open.
Does he have any kind of tumors within the lung that are going to cause him to have need for thoracentesis or anything like that?
He wouldn't want a thoracentesis. He doesn't really want anybody. He's one of those guys that kind of doesn't like doctors. He really doesn't want us to do anything to him or for him. Trying to even let us take care of him was a challenge. Now he's sort of come to trust us. But he's not going to let me near him with the thoracentesis needle. Much as he says he likes me. And that's okay. And so that's a good thought. If he had a pleural effusion, if he had fluid that could be tapped, then that might be something that would buy him some time. Those taps usually work fairly well the first time. And then after a certain amount of time, the fluid recumulates. And so maybe you do it again. And the next time it recumulates a little bit faster. So maybe you try it again. And then pretty soon you realize that you're sort of in a cycle. And so at the end, it seems to have limited helpfulness. But keep in mind that when we say, so when I dictate on a patient, I say, this patient has a terminal illness and a prognosis of 6 months or less if the terminal illness runs its normal course. So the terminal illness doesn't always run its normal course. And when the patient gets to 180 days on hospice, we don't kick them off. They're reevaluated, actually it's at 90 and then 90 and then 60, 60, 60 forever and ever. And as long as they continue to meet that, so I say prognosis of 6 months or less on day 1, and then in 90 days I have to recertify them. And if at that point they have 6 months or less, then I can recertify them. The patient has a prognosis of 6 months or less. It's not now 90 days, it's still 6 months, and so in 90 days I come back and say, I still think this patient's going to die in the next 6 months, and as long as I can back that up with the clinical findings, I mean, I've had patients stay on hospice as long as almost 4 years. I had one patient who stayed on hospice, and she had metastatic breast cancer. And the thing with cancer is that hospice was sort of born out of oncology, and so it's kind of a slam dunk for oncology patients. If you have metastatic stage 4 cancer, then you can kind of be on hospice for as long as it takes. So that was pretty easy. Now, not all patients, we can get into prognosis and we don't need to, but so patients who continue to have, I mean, she had multiple metastasis and was on large amounts of medication. She was a really an amazing person. And we were very blessed to take care of her. But she lived 3.5, 4 years on hospice care. It's very hard on my staff when she died.
Martin, could you comment on the financial analysis of the hospice program? Overall, there are a lot of services that are provided which are not provided to Medicare patients. They cost money. Is that made up for in terms of decreased costs, expenses in other ways? And so does the program pay for itself, or is it an additional financial cost to the Medicare system?
Much to many politicians' dismay, hospice is really a huge money saver. It really is. If you just think about, if we have a person who's on hospice care and they don't go in the ICU and get on the ventilator one time, how many thousands of dollars that saves for one patient, for one admission. The whole objective of hospice care being to allow patients to stay at home and be treated there rather than going back to the ER, back to the ICU. Hospice is paid on a sort of a microeconomic level. Hospice is paid a per diem rate per patient based on their level of care. So 80% of our patients are routine home care. The average Medicare reimbursement is something like $140 per day per patient. Out of that, the hospice provides all of the nursing care, all of the medications related to the primary diagnosis, the DME, all of that. And so it's, Medicare sort of has, it's almost like a capitated plan, if you know what that is. Medicare knows what it's going to cost to take care of this patient going on, and so there aren't a lot of surprises for them. So it's really good financially for Medicare, and it's good for patients because we do cover a lot of medications and DME for patients that wouldn't necessarily be covered under regular Medicare Part A. Do have occasionally patients who only want to be on hospice because we pay for their medication, and that can sometimes be a conflict of interest, I think. But that's a whole other lecture. Does that help? Does that make things more clear or less clear? Overall, hospice is a good thing. It's a good thing for the economy. It's a good thing for the patients. It's the right thing to do for the patients. If that's what the patients want, then they should be able to do that. You know, the post form and the durable DNR forms and advanced directives, they're funny things because they are like legal documents. The post form has to be signed by a physician. It's a quirk in the state of Tennessee that makes nurse practitioners and mid-level providers, PAs, and clinical nurse specialists very grumpy. And actually, frankly, it makes physicians very grumpy as well, because oftentimes, like for example, my hospice and palliative care nurse practitioners, they have these discussions. They're 20,000 times better at having these discussions than lots of the physicians that they have to have countersign these things. But it's just a weird thing in Tennessee, and we've tried to change it, and we're trying to change it, and hopefully it will change. But if the patient changes their mind at any point, they can change their mind. They're allowed to. They can be, do not resuscitate, do not intubate, blah, 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 blah. But when it comes right down to it, if they say, you know, I changed my mind, I want CPR, put me on the ventilator, that's what they want. Likewise, they should be able to go the other direction too. That's a little bit not as clear, and also gets into some ethical issues that probably don't need to be addressed right now. I think if the patient says, don't do CPR on me, and then you do it, I think that's a problem. However, the hospital's lawyers somewhat disagree with me on that, so we won't go too far down that road. It's just one of those things. It should be what the patient wants, so hopefully that's what's recorded. Okay, here's another case. Nancy is an 86-year-old female who has a non-operable intracranial hemorrhage, so she's bleeding in her brain. She's unresponsive. She's in the ICU, she's on the vent. She's been hospitalized for intracranial hemorrhage before, and she had a gastrostomy tube placed previously. Her husband states she's been through this before and she's gotten better. I want everything done. Everything done. Family wishes to continue aggressive care, including tube feeds, and wants her to be full code. Is this patient a candidate for hospice care? Yeah, she is. I mean, she is a candidate for hospice care. There's nothing in this that tells me that she can't be in hospice care. Makes me wonder if the family is really on board with hospice. But there's nothing specifically here. She can be a full code. She can have tube feeds. There's nothing else. This is an inoperable intracranial hemorrhage, so no craniotomy is going to be done, nothing like that. It's going to be medical management, and if she has a prognosis of 6 months or less, then she can be a hospice patient.
Does she have advanced directives?
She does not. She doesn't. What should the medical team tell the family? Imagine you're sitting down with this family. You're the palliative care doc. You're in the ICU. The critical team says, I got this problem. Fix it. Where do you start?
I think you have to ask them what their goal is. What do you want out of this?
Good. That's always a great thing to start is you know, where are we hoping to get? One of the things that I do in palliative medicine is I help people to set goals. And when I start talking to people about their goals, then sometimes I can bring in, some families are more receptive than others, but sometimes I can bring in the fact that I have to be there to help them to make appropriate goals, reasonable goals, goals that could be attained. Because really, this husband thought that she was going to go home and be fine again because she was fine the last time. But she wasn't going to be fine this time. And it was very difficult for him to understand that. And sometimes the hardest patients to deal with are the ones who have been, when you're talking code status, are the ones who've been coded before and have made it and have gone on because they're like, well, I don't know, I was on the vent before for 2 weeks, it wasn't that bad, I'm here now, I guess I'd do it again. And you're thinking, oh, yeah, but now you've got this big bleed in your head, you know, it's a different situation, but they have this feeling like they did it before, they can do it again. So this was a very, very difficult family. Eventually, they did understand through multiple discussions with all of the treating physicians that there wasn't anything else to offer her in the ICU. She was taken off the ventilator, and we took her to the hospice house, and she died peacefully several days later. But every time at one point she was squeezing one of the family members' hands, and I mean, instantly the family was on us. She's getting better, she's getting better. We have to take her back to the hospital because she's going to get better. She's going to go home. She got better before, she's going to get better. It was very, very difficult. They did fine with her death. Eventually they did come to understand, but families, again, not an easy case. Some families have tough situations. Okay, artificial nutrition and hydration at the end of life. I did this as a grand rounds at Bristol Regional Medical Center not too long ago. That was an hour-long talk. You'll be happy to know I took out about a third of the slides. So, but it's a really interesting topic, and it's something that I think that everybody can relate to. So the background. Food and drink are very important in most cultures. We talked about that. This makes it really complicated when a loved one stops eating and drinking at the end of life. But loss of appetite and decreased need for fluids are part of the normal dying process. Families often fear that their dying loved one will be hungry or thirsty, and they feel that IV fluids and artificial nutrition will help with this. So that's where we start. Patients often refuse food and fluids at the end of life. I love this cat. He reminds me of my hospice patient. They may have anorexia, which we talked about due to the disease process. Their sensation of taste changes. They may have mouth sores, thrush, nausea from the disease or from the treatment. They may have nausea from the medications we're giving them. They may have pain when they swallow. Again, a lot of times, if they have candida, the candida will even get in their esophagus. Makes it very painful. You can treat that. If you can treat the underlying condition, maybe that'll help. Sometimes it just doesn't. Sometimes they're completely unable to take in nutrition and fluids by mouth. They may have obstruction or mechanical issues. They may have altered level of consciousness and just not awake enough to eat. They may have such severe nausea and vomiting they can't keep anything down. Maybe their swallowing is just disordered and they just can't do it due to stroke or anything, brain tumor or anything that causes that. So we have some methods. We have some ways of getting food and fluid into people anyways. So, if we're trying to get nutrition into people, we call artificial nutrition any non-oral method of administering nutrients. So, it can be enteral, which means into the gut. So, this is by nasogastric tube, PEG tube, which is a G tube, which is placed directly into the stomach. A J tube is placed into the jejunum. So, we put all kinds of tubes into people, and then we can dump tube feeds in there, and they go straight into the gut. Or we can use an IV line, and we can use total parenteral nutrition, that's TPN. PPN is partial parenteral nutrition, which is usually used if people are still taking some food but not enough. The key here is if you can use the gut for nutrition, you should use that rather than the IV route. It's better to be putting something in the gut than not to. Although there are times when you just simply can't use the gut, and you can use IV feeds if you need to. For artificial hydration, you can give fluids a number of ways. You can, of course, give fluids intravenously. You can give fluids subcutaneously. This is called hypodermoclysis and is sometimes used in hospice care. You can put fluids rectally called proctoclysis, and I have to say that I've not ever done that, but I've read about it. You can do it. Or you can put them in enterally through the same tubes that you would use to feed someone. Okay. So how much do we use this? So I did a lot of research for this. Approximately a third of nursing home patients with severe cognitive impairment and feeding problems have feeding tubes. That was in 2003. Feeding tubes used, this is mostly feeding tubes. They're used in many diseases, cancer, especially of the head and neck, because you can see where you would have problems with eating. So it's easier to just bypass it. Stroke, dementia, ALS is amyotrophic lateral sclerosis, Lou Gehrig's disease, and persistent vegetative state. Evidence shows that artificial nutrition and hydration is more helpful in patients who have a temporary condition. it turns out that it's a pretty good bridge to getting someone to eat and drink on their own again. So in those situations where there's something temporary going on, it's a good idea. However, it's often initiated for patients whose conditions are very advanced and the prognosis is very poor, and it has much less efficacy in these patients. So how come we do this? Often the goals of artificial nutrition and hydration are to prolong survival, to prevent or promote healing of pressure ulcers, to prevent aspiration in patients with dysphagia, to increase patient comfort, and to ameliorate end-of-life symptoms associated with malnutrition or dehydration. So this is when they're saying, I just can't stand to see daddy starve to death. But there's no compelling evidence that ANH achieves any of these objectives. So the literature is really very poor on using this in end-of-life patients. So what did it say? So there was a review study done in 2006. It reviewed 32 studies. There's not, and I will admit, there's not a lot of great research done on this. Of those 32 studies, 21 were case series with no controls. So for the 11 that were controlled and none were randomized, I guess it's kind of hard to randomize. It'd be pretty hard to do like a placebo feeding tube. It's kind of there or it isn't. But of the ones that they could do, 7 showed that enteral feeding did not prolong survival, had no effect on survival. 3 showed that it increased the mortality, so it actually made life shorter, and only 1 out of the 11 showed any increase in survival. A 2007 review article, randomized trials of enteral nutrition, concluded that there is no justification for enteral nutrition over a wide range of disease states. So these patients that we're doing this to, unless we're bridging to something, or in certain situations, and I'll talk about when it's beneficial, we put a lot of G-tubes in people that probably don't need them. So there is some evidence supporting artificial hydration at end of life. So this is hydration. This is IV fluids. The results are still mixed for amelioration of altered mental status due to dehydration or opioid use. So if the patient has dehydration or is on opiates, and we think one of those is the cause of altered mental status, then a short-term trial of IV fluids has been shown to be helpful. So those are the patients that all use fluids in hospice care. Literature has no support for artificial nutrition and hydration to prolong survival in a terminally ill patient, to ameliorate thirst or dry mouth, to increase comfort, to promote healing of wounds or pressure ulcers, or to prevent aspiration. So often, our dysphagic patients are just automatically put on a feeding tube, put a feeding tube in because we think that it'll stop. But the literature's been really equivocal on whether or not this actually stops aspiration or decreases the risk of it. There's not been good evidence to show that it does that. So what harm might we do with using this? Risks of artificial nutrition hydration include perioperative complications of PEG tube placement. It's a surgical procedure. Anytime you cut the skin, you can have problems. Aspiration of tube feeds. Remember, no decrease in aspiration risk with PEG. Some of these ones that are coming up are really important for me. Loss of pleasure from eating and drinking. Some of these patients, even if they can only eat or drink a little bit, even if they're at risk for aspiration, they still derive pleasure from eating and drinking. And part of that is the interaction with other people. Imagine a patient who's in a nursing home who has late-stage dementia, and she has somebody coming in and feeding her small bites of pureed food. It's probably not fantastic, but she has that one-on-one, that FaceTime with another person. Send her to the hospital, put in the PEG tube, send her back to the nursing home, and guess what happens? She lays in bed with the tube feed going into her gut, and guess what we have to do now? Because anytime you stick a tube in someone, what do? They try to pull it out. So now she's got to be in restraints. You see where this isn't really working for this patient? And it's not really shown to increase her survival. When we put fluid into people, either as a form of nutrition or as a form or hydration-wise, we risk fluid overload. I explain to families often that at the end of life, so this is my layman's talk. I say, at the end of life, the patient's body stops knowing what to do with fluid. And you can see this happening. What we do, we call third spacing. The food and the fluids may go into the gut, they may go into the vein, but where do they end up? They end up in the lungs, they end up in the peripheral tissues, right? They get swelling, they may get regurgitation, they may get diarrhea, they're going to be at risk for a lot of things related to fluid overload. Nausea, vomiting, diarrhea, increased pulmonary and gastric secretions, and we talked about death rattle and how we try to dry people up at the end of life. The more fluid you put in them, the more fluid they've got in them, and the fluid's got to, it's got to go somewhere. They may get ascites. So there's a lot of reasons not to fill people up with fluid at the end of life. Okay, so let's talk about symptoms, because this is really where the rubber meets the road. People want to know about hunger, thirst, and dry mouth. This is what the family's worried about. I'm afraid he's hungry. I'm afraid she's thirsty. So the literature showed us that most patients do not feel hunger at the end of life. And if hunger does occur, it can be ameliorated with small bites and sips for comfort. So we do what we call feeding for comfort. We put a tiny amount of food, of something the patient likes. Maybe it's usually something that's soft, pudding, mashed potatoes, ice cream, doesn't matter. Popsicles are another one that my hospice nurses like to use. Because really it's about the taste of the food. The taste of the food and having something in your mouth. If we put the food directly into the gut, we've shown that it doesn't really help. Likewise, thirst sensation diminishes with age. We know that, and also it diminishes with chronic illness. So, patients may want ice chips, sips of fluids, and popsicles. Dry mouth is not improved with IV fluids. Good oral care is so important. Ice chips, artificial saliva, which I always order on my comfort care patients in the hospital, but I never order in my hospice house patients because my hospice house nurses are so good at doing oral care. And at the end of life, oral care is a big deal. Keeping the mouth moist. It also allows you, and I have a slide in here, I guess maybe this is it, where I talk about teaching the family to do oral care. You get the little sponges, teach them how to put the water in it and let them do it. Families have a need to do something at the end of life. Now, they're not going to turn into nurses and want to or be able to do a lot of complex nursing things, but just letting them moisten the patient's mouth, letting them put a little caramel on the lips, those things, giving them those jobs. This is your job. This is what you can do, and it'll really make a difference for your mom. It's huge. It's really important for people. So we talked about small bites and sips of food for comfort, providing good oral hygiene and mouth care, keep the mouth swabs at the bedside, teach the family to do good mouth care, and emphasize the interpersonal contact, because that's another thing that's really important at end of life. And it's important for the patient and it's important for the family to have that face time and be able to do something hands-on to make it better for their loved one. Okay, so what happens next? Survival after cessation of artificial nutrition and hydration obviously depends on the patient's general condition and their ability to take in POs. If they can still take small amounts of food and drink by mouth, they may have survival of weeks to months. Remember back to that slide about 650 slides ago when I talked about the fact that patients who are resting don't have a very high caloric intake? You'd be surprised, a teeny tiny bit of food and fluid seems to sometimes make patients go on forever. If the patient is taking nothing by mouth, we usually figure survival is a few days to short weeks. So that's what you can expect. So what if the patient's in hospice care? We've talked a lot about hospice care. Hospice care does not mean that artificial hydration and nutrition are out of the question. In the patients for whom it's appropriate, I have no problem using it. Patients who have been on tube feeds may continue, it must be getting late, sorry, I've been talking a long time. They may continue tube feeds. Each case is evaluated individually. Generally, most hospice patients, from what we've just heard, would not benefit from artificial nutrition and hydration. Those who might benefit, like those who would have altered mental status due to, say, perhaps opioids, I would certainly consider a trial of IV fluids to see if that would help clear it up. If it doesn't work, then we can stop it. And then we know we've tried it. And sometimes just doing that